Dietary fat and ketones are preferred by the lymphatic system, and it and actually can cause new growth of lymphatic vessels. And so this is what's been so exciting. And I'm trying to convince the lymphedema lymphology community because it's just a very small fraction of us that are understanding that the nutrition model that we've been using, that we're trying to promote with people with lymphedema and everybody else, is so wrong.
Okay, good morning, everybody. We've got a special speaker today. Leslyn Keith is here.
Good morning. Great to be here.
Yeah, thank you. I had your colleague weeks back, Catherine Sao, and she had mentioned you kind of have a different role in their particular organization. So first of all, welcome and thank you for speaking to our community. I know people will be kind of pouring in as time goes on. They'll probably have some questions for you. I know this is a topic that at least some members of our community are, interested in, and some of them struggle with. And so it's good to hear some more expertise on it. So if you don't mind, would you please provide your sort of background history for us so we know who we're talking to? I know you're an occupational therapist and specialize in lipedema, but can you give us fill in a little more details if you don't mind?
Well, and I would just amend that to be that I specialize in lymphatic disorders, because I original started a lot with lymphedema until I met Catherine in 2016. And then we started really working on lipedema. But before that, I was a lymphedema therapist for 20 years and started using a ketogenic diet in my practice to help with my patients. The overwhelmingly number of the patients were obese along with their lymphedema. And so I was struggling to find a way to help with that, because I was trained like everybody else that, eat less, move more, use a plant-based diet, use a low fat, low calorie diet, and that should work. And of course it wasn't. So found out about keto and started experimenting that with my patients. And eventually got my doctorate in occupational therapy just so I could do a study on how this, if it would work for patients who had lymphedema and obesity, and would it reduce their weight, but also then their swelling would go down. And it worked spectacularly. So I've been exploring it more and more ever since then. And of course, now looking at Carnivore.
Yeah, that's interesting. You mentioned lymphedema, and some of the people that maybe not have quite the medical background. I would see that a lot you see it particularly with breast cancer patients, because there's often a lymphatic dissection in the axillary, and women end up with these swollen arms. And I'm sure you treated them with the compression sleeves and all that type of thing. So I imagine you probably saw quite a bit of that. And the obesity goes with, obesity is a significant risk factor for breast cancer. So that is pretty interesting. And I would typically see, not so much lymphedema, but we would see swollen arms from, humerus fracture. Little ladies fall down and break their proximal humerus, and they've got a big swollen fat hand, and we're having to try to work that out with the occupational therapist. So how do you think, because lymphedema, how is a ketogenic diet potentially impacting the lymphatic system? Because that's something most people wouldn't sort of, kind of relate to those two things. How do you have a mechanism you might be able to describe?
Yes, and that is what's so interesting, because what we were looking at before is that the way to get the swelling out was that the obesity was impeding it. And so we just get the person to lose weight, and then the swelling would go away. But the thing is that I was having patients who were having reduced swelling who didn't need to lose any weight. And so there was obviously something else happening that was so interesting. And so what we are finding now, mostly with animal studies, but they're very promising. There's a few small studies with human subjects, but what we're seeing with animal studies is that carbs are inflammatory to the lymphatic system, actually cause swelling and decrease transport capacity in the lymphatic system, and cause an increased lymphatic load, so increased fluid in the tissues. And then, not only that, fat is really important to the lymphatic system. And so dietary fat and ketones are preferred by the lymphatic system, and actually can cause new growth of lymphatic vessels. And so this is what's been so exciting. And I'm trying to convince the lymphedema, lymphology community of, because it's just a very small fraction of us that are understanding that the nutrition model that we've been using, that we're trying to promote with people with lymphedema and everybody else, is so wrong for the lymphatic system. And now we're finding out, at least anecdotally, that even going towards animal sourced foods is going to be even better for the lymphatic system. And that I don't have any empirical data on that yet. It's all anecdotes.
Yeah, it's interesting. You mentioned inflammation, because there was just a large systematic review, meta-analysis of quite a few studies looking at low-carb ketogenic diets for inflammation in regard to chronic pain and neuroinflammation. And they found something like the vast majority of the studies saw a significant reduction in inflammation across the board with those types of things. So, I think clearly, and that's something I saw as a surgeon, just the amount of swelling people would have post-operatively was greatly decreased with, low carb ketogenics and animal-based diets. And so I think that's something that there's definitely something there. So I think Catherine said that you were, you really obviously just mentioned you have your PhD, so you've been involved in the research side. So let's talk about some of the research you've done. And I know we want to talk a little bit about lipedema, but I still think that the general inflammation, the general lymphatic system is also very pertinent, and we need to, understand about that. So what has your research focus been over the recent years? And can you talk about some of the things you've discovered?
Well, so the research project that I did when I was getting my doctorate was in lymphedema and obesity, and using a lifestyle that promoted keto. And so I had 12 participants that were in that, and all had a BMI of at least over 30, and then presented, here's the ketogenic diet, here's how to do it, and here's why it would help you. And I naively just kind of thought, oh, well, everybody, of course, will do it because of course science shows that it works. And so it was quite enlightening for me to see that no, not everybody wanted to do it. But I had, of the 10 people who remained in the study, 6 did it and 4 did not do it. And the 4 were very apologetic, but I said, no, you actually gave me a nice comparison, because even though it was very small groups, it was very startling the amount of fluid lost, percent body fat lost, weight lost, decreased pain, all these things that were so overwhelmingly better with the group that used the ketogenic diet. And so then I presented that research at the NIH meeting on lymphatics in 2016, I guess it was, and I met Catherine, and we started talking about lipedema. And so since we've been working with that, we're interested in getting started on a couple of different projects. One is the blood profile of women with lipedema. So that is that abnormal deposition of fat to the lower body. You have almost 2 different bodies, a normal looking upper body, and then the lower body it can be quite large. And so we're interested in that blood profile, because we hypothesize that even if these women tend to not have type 2 diabetes and elevated A1C, they probably do have elevated insulin. And so we'd like to test that. Interesting talking to Dr. Paul Mason. He has a theory that they also have elevated LPL, lipoprotein lipase, which might be promoting the fat deposition. And so we have seen in some studies there's elevated cytokines in lipedema fat. And so we wanted to look more at that. And so just a lot of interesting things that we want to see with just the blood profile that we think might be missed most often with the wrong way that we actually look at people who are probably on the road to diabetes, and we're missing that. So we really want to do something with the blood profile. We're talking with Dave Feldman and Siobhan Huggins, because they have Own Your Labs, and they have a way of collecting data and stuff like that. So, and Siobhan herself has lipedema. I think she spoke for this group. So we're looking at that. And then we're also looking at a qualitative study about the impact, the social, emotional, psychological impact of lipedema has on women. And we have miles of video of women in their own voices, what their experience is of their condition, of trying to convince their doctors of what's happening, and trying to manage their condition. So we're going to do some kind of qualitative research with that.
So you mentioned that, the lipedema as opposed to the lymphedema folks have kind of, it seems like there's maybe some common demographic or common pathophysiology going. What have you seen? Like you mentioned diabetes, or some of them are pre-diabetic or hyperinsulinemic. What is it? What would say, outside of the pathognomonic lipedema, what are the things you typically see with these typically women? As we know, it's like 99% women. What are we seeing outside of just the lipedema? What are the other common traits?
Sure. And then let me first, I'm going to just define for you all lymphedema. And so it's pretty rare to be born with lymphedema or to have a primary or hereditary condition, but you can have an impairment, an innate impairment to your lymphatics. And so fluid is not being collected from the tissues appropriately. And so you get swelling that can appear right away or not until years later. And the other type of lymphedema is much more common, is secondary lymphedema. So due to surgery, cancer treatment, trauma, something that can destroy or impair the lymphatic system, lymph nodes removed, cut, damage, whatever happens. And so now again, you get that swelling into a body area because it's not being evacuated by the lymphatic system. So interesting, lymphedema is a fluid situation that ends up getting a adipose tissue or a fat component, because that stagnant fluid ends up attracting or causing the proliferation of fat into that area. So that really large arm you get sometimes after breast cancer treatment is not just fluid there, it's also adipose tissue that has proliferated, versus a woman with lipedema. Could be genetic, could be a metabolic issue, could be hormonal, it could be many different things. But typically she starts seeing something around puberty, pregnancy, or menopause. And so we get the proliferation of adipose tissue that then, because of the decreased circulation and the inability of the lymphatic system to appropriately remove fluid from the tissue, it's a fat situation that gets an edema component. And so they're similar, but almost on the opposite end of the spectrum. That one starts as fluid and then attracts fat, and the other starts as fat and then attracts fluid. So you end up with this mix of problems with fibrosis and stagnant fluid and excess of adipose tissue.
You mentioned, this proliferation of the fat in lipedema, as well as little, to some degree, in lymphedema. Do we know if that's a hypertrophy phenomenon or is it actual hyperplasia? And the difference, one is the cells get bigger, and two, the cells multiply. So, do you have an idea what's going on with either of those?
So there was a paper on that they said it was more of a hypertrophy issue. But I wonder, when we get to I think Catherine showed you some very, very large proportions of women. You just wonder if there's also some hyperplasia as well. But they said it was primarily hypertrophy with a lot of macrophage and cytokine activity, poor, you weren't getting oxygen and nutrients, and no evacuation of waste products from the tissue. So really poor circulation to that fat tissue. So there was some similarities with obesity, but also, especially with the cytokine profile, it was quite different from obesity fat. And it could be on the same woman. So with her obesity fat, the tissue could be analyzed, and then you look in the areas affected by lipedema, and it can be a different cytokine profile.
Do we have any, I know, like I've seen biopsy studies on human fat, and there's been a qualitative difference in the kinds of fat that we're depositing as human beings. over the last 50 years. Some people would contribute that to the different types of fat we're eating. Some people would say that we're eating more soybean oil and less butter and beef and that type of stuff. Is there any evidence that there's some sort of qualitative difference in the fat, other than the invasion of macrophages, but the fatty acid profiles in a lipedema person?
And I have not seen a paper on that yet, but that would be another interesting avenue that we should do for research. Because I do believe that there's also, because of our food, the way we're eating in the last 60, 70 years, that that is exacerbating a woman who's predisposed to get lipedema. And maybe if she was never exposed to that type of eating, that she might not have developed such a severe issue with lipedema. That would be interesting to see.
Yeah, I think it would be. It's something that I can remember as a surgeon, and I cut through a lot of body fat, believe it or not. And sometimes the fat quality was just different from one person to the other. It's kind of a little weird to talk about, but some people it's a different color, it's a different texture. And it was just, it just had a really different feel to it. And it was just kind of wondering what's different from one person to the other and how their diet seems to impact it. Because you did mention, ketogenic diets, and you started to allude to a carnivore diet having some efficacy in the treatment of, either lipedema or perhaps well, both, I guess.
Mm-hmm.
Why do you think the diet has a role there? Isn't it just about, because a lot of people would say that, obviously when we talk about weight loss, it's about a caloric deficit. And my response is there's some truth to that, but I think the diet quality has a role here too.
Mm-hmm.
Why do you think ketogenic diets uniquely, I guess maybe, do low-fat diets equally work for lymphedema or lipedema, or are you finding more efficacy with the ketogenic style diets?
Well, I'm finding that with lipedema, low-fat diets don't work at all. They will only lose body fat on the upper body, and quite often start losing some muscle on the upper body before, and just nothing happens on the lower body. But for both lymphedema and lipedema, what's happening with the lymphatic system is the carbs are actually inflammatory to the lymphatic system. And so, for instance, on a mouse study, they showed they wanted to induce a metabolic syndrome in mice. So what did they do? They fed them a high fructose diet. And then they looked at what was happening inside the lymphatic systems. And the mice on this high fructose diet, the lumen inside their lymphatics was so swollen that it reduced their transport capacity by as much as 50%. And so now you're not evacuating that stagnant fluid. And so here's what's interesting is the lymphatic system actually has crosstalk with the nearby adipose tissue. And if there is an acute inflammation like an infection, it contributes to lipolysis, or breaking down of the nearby fat, to power the lymphatic system to help with that immune emergency. But if there's a chronic inflammation, such as with that excessive adipose tissue deposition, it's going to cause more fat to come in, because it feels that there's a need for energy stores for a long time. And so you get that fat proliferation. So now if you have a lot of fructose in your diet, or I think probably other inflammatory carbs, you're going to have stagnant fluid because you have reduced transport capacity. And that stagnant fluid is going to send a signal of chronic inflammation. Let's cause more fluid to be here. And then the other thing is that the lymphatic system is responsible for transport of long chain fatty acids as well as fat soluble vitamins. And so now we're getting if we're not eating fat, we're not giving the fuel to our lymphatic system to do what it needs to do to grow new vessels or whatever it needs to do. And it also is meaning we're getting possible vitamin deficiencies in our body, systemically. And women with lipedema, they did one study showing the values for vitamin D are actually lower than the general population. They tend to have, and that may contribute to their inability to lose weight because they have such low vitamin D, and then it ends up also contributing to mood disorders. So I think that there's a twofold thing that's happening here, that we're reducing that lymphatic load, which is not then causing a proliferation of more fat. And we're also contributing to the health of the lymphatic system and our body in general by allowing us to get all these fat soluble vitamins and other nutrients, and in a more bioavailable form. So vitamin A, there's actually was a study with vitamin A that the animal source of vitamin A is actually may prevent lymphedema post-surgery, because they were doing this with rats again, but supplying them with the retinoic acid post-surgery, and then they weren't getting lymphedema forming after lymph node removal. So vitamin A in that bioavailable form from an animal source is going to be so much better. Right now, the evidence out there is flimsy, but we do have a lot of people trying carnivore, really cutting out any plants in their diet. And whereas keto worked to a point, then as soon as they cut out the plant sources, now they're continuing to improve, not only in weight loss, but in other symptoms as well. So, pretty soon 10,000 anecdotes is real evidence, right?
Yeah, I mean, you'd assume so. I mean, there's people that no matter, I mean, they'll point to an epidemiologic study, which is basically a collection of anecdotes using, patient recall for food frequency questionnaires, and they'll accept that as a study. But if you show thousands of people that have, reversed whatever disease, they still claim it's not worthwhile evidence, which I think it's still evidence, depending on how what you do with that is where we have to go next. Let me, this one of the things that I keep seeing this vitamin D. Vitamin D is associated with better COVID outcomes. Vitamin D is better associated with vitamin D status, I should say, so serum vitamin D levels. But when we often see that when we supplement with vitamin D, particularly in the form of vitamins, it doesn't seem to make that much of an outcome difference. And so my often thought is maybe vitamin D is a marker of underlying metabolic health. And if you don't fix that, and maybe by, if you're including animal source foods to get your vitamin D, where some people do, whether it's through fatty fish or things like that, it may be that you're still removing those other things that are still problematic. And, you're because you're substituting, and it's maybe the removal of the other things rather than the addition of, which is interesting, because I don't know which way the causality error goes. And I know one of the answers, it just seems like we just need to pour more vitamins into us. And I suspect if you supplemented lipedema women with high dose vitamin D, I think the effect would be less effective than if you clean up their diet.
Yes.
This is my
Yes.
speculation.
Yes. Well, and any amount of vitamin supplementation is not going to do any good if you're still eating a poor diet. So that's what we're stressing in the lipedema community, is that's the first thing you got to do. Yes, there's lots of other things that we can do to help your situation, but if you don't have the diet, nothing else is going to be as effective.
Yeah, and I remember Catherine mentioned something. I can't remember the number, but it was something like 15 million American women or so, somewhere in that neighborhood, were suffering with lipedema, which is far more than a lot of things. Diabetes is only, it's only something like 30 million. Diabetes is about 9% of the population, so it's roughly 30 million. So it's a pretty prevalent disease. Obviously there's different stages, and not everybody has the most severe form of that. Do we see similar levels of incidence in other countries and other populations? Do we see that, say, in Africa and Asia? Is it quite as the same level of prevalence, or is it kind of unique to Westernized societies?
So in our community, since we're doing everything on Zoom, we do get women from around the world, and we do have a good participation from African countries. And just in general, when we look at estrogen and the impact it has on the way women gain weight, African American women tend to have that more of a pear-shaped weight gain and higher estrogen levels, and they tend to be more problems with becoming insulin resistant. So I think that and just that pear shape, that type of weight gain does not mean necessarily lipedema, but I think that we do see that the propensity for lipedema in the African American and African population. We have participation from all over Europe and some of the best researchers. We have Joanna Dudek in Poland, who's doing a lot of stuff in Poland. So I just saw a great keto study coming out of Russia with women with lipedema. So I know it must be an issue there as well. We're not seeing it as much in Asian populations I'm not sure what the reason is there. Definitely, we're seeing it throughout the US, North America. And then we're talking with a surgeon, Dr. Amato in Brazil, who is using also keto with his clients. He is actually a surgeon and does liposuction for lipedema, but he wants them to see if they can do well with keto first and other lifestyle things. So he would prefer not to do the surgery. And so I know that it's a big issue in South America as well. So I think it's pretty spread through most populations.
You mentioned, when you first started doing your research, you struggled to get people to adopt a diet, to make a dietary shift to I guess, a ketogenic diet or whatever. Has time changed that for you? I mean, you obviously demonstrated more success in this lipedema population. Does that sort of give people more hope to sort of buy into it and actually do it? Are you finding less resistance to dietary changes for this?
Yeah, it's so interesting that it's almost like they have to have a certain level of desperation to want to make a change that first they think is probably not good, because goes against everything that they know. And their doctor tells them not to do it, and their family tells them not to do it. And so it's very, very hard to overcome that unless they're going, this is, as is the case for women with lipedema. They are desperate. They have tried so many things and they see their health declining severely. Maybe it's easier with people who have full-blown type 2 diabetes and are taking huge amounts of insulin and they are starting to have kidney problems and all these issues that are piling up. And so they're willing to make the change. But what I found with my patients with lymphedema, that things weren't bad enough. And so they weren't willing to learn more about nutrition and what could possibly be happening, because it wasn't at that state yet. But I did find that sometimes it just took a long time for the message to get in. I did work with a gentleman for about 2 years before he decided to try it. And then when he did it, he lost over 100 pounds and his swelling went down hugely, whereas nothing was happening before. So sometimes it takes a while to get to that point that, okay, now I'm ready. I didn't believe you, but I'm willing to try it. So, and it's sometimes because it takes so long for, them to see something happening with lipedema. In 2 weeks or less, their pain could be halved or totally resolved. And so that's pretty motivating. But with someone who's just overweight and not as having very many problems, their lymphedema is not giving them that much trouble, it's not painful, then, waiting the 3 months to see a change, maybe it's harder to take that leap in faith.
Do you see, with the development of lipedema, is it like this happens from basically birth on, if this is a fat deposition pattern, or is there something where, they initially have sort of more symmetric fat and then something changes and then all of a sudden they develop the lower extremity deposition, or is it always pretty consistent?
So that is interesting, and why they're looking at estrogen and other hormones, because it seems to typically during when we have hormonal upheaval. So puberty is the most common time that this happens, but also puberty, pregnancy, and menopause are also a time when we have natural insulin resistance. So is this, do we have that propensity towards a pear-shaped fat deposition? and lipedema. And then you combine that with a bad diet at a time of natural insulin resistance. Is that what's causing it? Another reason why we want to look at that blood profile of what's happening to women. So I think that, and also a lot of them end up being low thyroid. So is that because of the repeated weight loss attempts, or is there, innate something with the thyroid that's going on? So I think there's a lot happening with various hormones. But typically they seem very, very normal until puberty. And some of them very, very normal until pregnancy, or some it really takes off at perimenopause.
Yeah, interesting. Obviously, I mean, anybody who is able to have a decent observation, women tend to deposit fats in different places than men. I mean, typically we see the men develop it around the gut, and women tend to develop around the hips. That traditionally has been associated with a better, at least cardiovascular risk profile. It's typically the belly fat that tends to be more sort of a problem when it comes to cardiovascular disease. Are you seeing women with lipedema having different risk profiles for cardiovascular disease or anything like that?
Yeah. So, and a woman with lipedema can have no abdominal obesity at all. Matter of fact, they can have a very, very narrow waist, and which makes clothing even harder to fit. And so, without that abdominal obesity, quite often we're having a pretty decent metabolic profile, and which can be a little bit startling to their physician, because they think that, there's all this excessive adipose tissue on the lower body. This must not be good. But then everything, the triglycerides tend to be low. The A1C tends to be more normal, but they're not always checking his insulin though. So they have a pretty good profile until they start putting on abdominal obesity. And with our way of eating, the typical way of eating, they're going to be putting on abdominal fat. And so in some papers, I see 80 to 88% of women with lipedema also have a diagnosis of obesity. So they do go together quite often. And then once you get obesity as well, and you get that abdominal fat, then our metabolic profile is no longer so good.
Yeah. What, as far as, dietary shifts, this is something that I see all the time, but it's always good just to confirm this. But when you put people on say a low carb, ketogenic, or even a carnivore diet, what is happening with things you're checking? Insulin resistance, other markers? Are you seeing improvements typically?
Yeah. So in when I did my small study with lymphedema and obesity, we did a comprehensive metabolic panel prior to having them do the intervention, and then did a recheck afterwards. And so they all had, the ones who used the diet had excellent improvements. But that was with lymphedema, and we have not done that with lipedema. But anecdotally, women are telling us that they do have improvements in their metabolic profile after they adopt the diet, which makes it a little bit tricky, to look at the blood profile of a woman with lipedema. Well, are you using keto? Are you using carnivore? Or are you eating the standard American diet? Because I think that's changing almost immediately, what their blood profile is.
Yeah, you do. I mean, certainly with things like insulin, sensitivity, that changes pretty rapidly. I know we've seen glucose levels. I mean, just with diabetics, I mean, within days, I mean, they're coming off insulin and medications, blood pressure improves. What about, you mentioned some of the inflammatory, macrophages and other cytokines that are occurring in there. Is there anything going on with, some of these adipokines that we see talked about, or other hormones like ghrelin, leptin, and things like that? Are those altered in the lipedema patient?
Yes. Okay. So the first one that I found out about that I thought was so interesting, because I was really focused on the lymphatics, is adiponectin. And interestingly, of the many things that adiponectin does, which is a adipokine, it it is responsible for the integrity of lymphatic vessels. In other words, to make the tighter junctions. And so you're not going to be leaking and losing fluid all over the place. And when you have obesity, you actually suppress the levels of adiponectin. And so now that's going to contribute to further swelling because the lymphatic vessels are leaky. So that was the first one I was looking at. And then it turned out that also adiponectin is highly involved in insulin resistance. And so you need to have those good levels of adiponectin. But then there was a paper that came out about leptin, and that there was an impaired expression of leptin as well. I mean, there's so many interesting things happening in lipedema. We tend to know more about that. But let me tell you, this was so fascinating with that whole thing about how fructose can cause inflammation in the lymphatic vessels and impair that transport capacity. So they did a fantastic controlled trial with women with breast cancer, lymphedema in their arm. And so they had one group that did what they called the weight loss diet group. So they had Nutrisystem, full of fructose. And then the other group did exercise. And then they had one group that did the Nutrisystem and the exercise. And they wanted to see what happened. Did they lose weight? And did the swelling go down? Because every other study in the past, you lost as little as 7 pounds, the swelling in your arm would go down. Okay, in that study, they lost weight on the Nutrisystem, but the arm swelling did not go down. And so I found just totally amazing. And the researchers were presenting this at a lymphedema conference. They're going, we cannot figure out what happened. They lost weight, and usually the swelling would go down. I happened to be doing a presentation after them. And so I don't think they were that pleased with me, but I said, I think I know what happened. I think that that at least contributed to that they had this high fructose, low calorie, low fat diet. And then the lymphatic system was so inflamed, it couldn't reduce the swelling, even though they lost weight. But there is such a barrier to understanding that, of course, it must be better to eat a plant-based, low-calorie, low-fat diet. This must be better for weight management. It must be better for health. And so when the outcomes don't match up, there's a total inability to understand what's happening. And I'm always so concerned about, am I doing that because I am so convinced this is the better way to eat? Am I blocking out and not accepting the possible good things that there might be from a plant-based, low-calorie, low-fat diet? But so I'm just curious what you think, Shawn, about how do we get that information across that it doesn't seem to compute most of the time?
Well, I mean, obviously there's people operating with it's almost like, it's ingrained in their thought pattern and they can't see outside the box in some ways. But it's interesting, because a lot of people would say, well, it doesn't matter if it's fructose or anything else, if it's in caloric excess, but the fact that they lost weight would indicate some sort of caloric deficit. How much fructose was delivered, in that particular, I can't say. I don't know. I'm not familiar with the study, but I know I've seen animal studies where it's something like 1 gram per kilo of body weight. Once you reach that threshold, so for the average, say, lipedema patient, you're maybe they're 80, 75, 80 kilos. Are they exceeding that amount of fructose in the diet? I don't know. Is there like I said, a threshold for fructose? And then most of the problematic studies tend to be overfeeding studies where we see saturated fat or fructose causing, say, fatty liver. That's what I'm familiar with. But you don't typically see that. You're right, in a weight loss scenario or a caloric deficit. So that's kind of fascinating that you've got that information out there around inflammation. But as far as how do you get the message out there? I think you just got to keep hammering and showing results, because that's what ultimately at the end of the day, is where the rubber meets the road is where the results are. And I think we're demonstrating that on a daily basis and getting more and more people that are at least open to the idea and starting to question the overall narrative. I think a lot of questioning is going on in general about a lot of things right now.
Mhm, mhm. Yeah, and what I found is that when I present this information to a keto or carnivore community, people are very interested and very accepting. Of course, yes, that sounds like that would work. But when I present the keto or carnivore information to the lymphology community, there is so much, not even more than skepticism. It's hostility and a barrier. They don't want me to keep talking about it. So I just find that so interesting. And I'm not sure how to do that, except for, as you say, just continue to keep making presentations.
Yeah, that's my strategy. And like I said, it's something that, I think people deserve to hear both sides of it. And, you're continuing to see little by little, 1%, 2% of the people starting to quote unquote wake up to this, or at least open their eyes to look at the data. But yeah, it's been very one sided, and there's definitely the nutrition world has got a very strong bias to it, and I think it's in no small part by there's some religious elements to our nutrition science. I mean, it was our American Dietetics Association was founded by Seventh-day Adventists, and so that bias has been there inherent ever since the creation of the field of nutrition science. So it's
Mhm.
interesting. Um, do you? I mean, when you said you entered these lipid or lymphatic meetings. That's a scientific community. I mean, are you finding that the scientists tend to be more resistant than the actual patients? Perhaps is that a fair statement?
Yes, yes, definitely. I think that's where I get most of my resistance. And then um, for the patients, I almost think that they would be willing to do it if their doctor was more supportive. And I found even within my study, when I had some of the participants had spectacular results. I mean, their blood profile was fantastic, more energy, less pain, less swelling. Everything was spectacular. And then they showed that to their doctor, and their doctor would say something like, "That is wonderful. Now, could you add a little bit more plants to your diet?" you know, so you have this fantastic response by eating this certain way, but now let's make it more like what you used to eat. So, but I did have one physician, a vegetarian. The patient came back to him with her spectacular results, and he started questioning, well, maybe my vegetarian diet and what I've been promoting to people, maybe is not so good. So he was a little bit more open to it and willing to not be opposed to, at least not be opposed to what she was doing, and also kind of questioning what he was doing for himself. So you get those little inroads every once in a while, but it's I find that the professional community is much more resistant than the general population.
Yeah, I mean, and I think a lot of times the general population doesn't have any pre-existing biases. They just know they're saddled with this condition they don't like, and they're willing to try whatever it ultimately works. I think one of the things you had mentioned is the support. I know we had done a large survey on this carnivore population. We saw that outcomes were affected by the support level of both their family and their physicians. So if they felt like they were supported, the outcomes tended to be better. And so whether that's a placebo effect, or maybe they're just willing to stick to it easier if they've got people supporting around it, it does make a difference for sure. And to sort of have physicians that won't support you is indeed frustrating. It's one of the reasons why we're doing what we're doing. We're looking to hire physicians that are, by definition, going to be supportive of what we're doing with regard to lifestyle and nutrition changes. There's a question in here about lipedema and the impact that exercise might have on that. Does that seem to help?
So it's not going to help with the fat loss and the pain reduction, but it is, of course, excellent to do. And particularly, what we're finding is the best exercise for lipedema as well as lymphedema is to be in the water, because we have that natural compression, and compression does seem to help with return of fluid, but also with supporting the tissues and decreasing pain. And so we do recommend when a woman is wants to get back into exercising, that is one of the best places to do it. It's, that's not low impact. It provides that natural compression and support for very, very heavy tissues. And so, yes, we definitely support that. There was an excellent paper that came out about doing aqua cycle for women with lipedema. And so they had those underwater cycles, and they were doing that form of exercise. And they had showed all kinds of benefits. And actually, it actually promoted ketone production, which I found was very interesting in that activity, because I don't think that these women in the study were on a ketogenic diet, but they had elevated ketone production. So, so definitely, I definitely promote exercise on whatever mode, way of exercising is going to be good for them. Definitely the women that really progress with a lot of weight loss and a lot of symptom resolution, when they are able to get to resistive exercise, that's even better. So it tends to not so much help them continue to lose more weight, but it changes the body composition. I've seen amazing before after pictures of adding the resistive exercise after they lost a bunch of weight, and their body volume just looks totally different. I think because of changed the body composition, and the scale is exactly the same. So definitely, when they're able to, we want them to get to resistive exercise.
Yeah, I mean, of course, I'm a big fan of exercise and particularly strength training. I think those are very important. You'd mentioned pain being a significant component of that. Is that part of the diagnosis for lipedema? Does everyone with lipedema generally have pain? Is that pain localized to the tissue itself, or is it sort of system, or is it kind of generalized? I mean, do these women have higher instances of fibromyalgia and myositis and myofasciitis and that type of stuff, or is it just localized to the lipedema tissue?
So it is very much, they could very often have a lot of the other pains you're describing, but this is specifically to the areas affected by lipedema. And quite often what's reported is a very, very light, innocuous touch can cause severe burning pain. So to those tissues, to that area. So, and I would say that not every woman with lipedema has that symptom, but a lot of them, I would say probably the majority of them do. So it is one of the distinguishing features of lipedema, but it doesn't exclude you that you don't have lipedema because you don't have this hypersensitivity to touch.
Yeah, it almost sounds a bit like, I'm sure you're familiar with what they used to call RSD, reflex
Yes.
sympathy, now it's been renamed to chronic regional pain system.
CRPS, yeah.
CRPS 1 and 2
Yeah.
and something else by now. But are you seeing, as far as, so we talked about diet, and obviously that's not the only way and the same thing what I talk about here. I mean, diet is a significant component of this, but there's other things we do. So what are as an occupational therapist or just a treatment generalist, what can be done for lipedema? Are there typically drugs associated with this too? Are people putting them on anti-inflammatories? What does a typical treatment algorithm look like?
Yeah. So the treatment that I'm trained in is complete decongestive therapy, and I do this. It's slightly different for lymphedema and lipedema, but in general, both of them will get a specialized type of massage, manual of drainage that helps move the fluid out of an area where it is congested in. And then we use some kind of compression therapy. And so the compression and any manual techniques that we do help to break up fibrosis. A lot of times this excessive adipose tissue gets, scar tissue and fibrosis in it. And so you want to break that up. And so using compression can do with that. So sometimes we wrap them with compression bandages. Sometimes if they're really hypersensitive to touch, we're using more gentle compression garments, some type of compression. We are using some kind of movement, whatever movement that they can tolerate to start with, using a lot of deep breathing. This is another thing with the lymphatics. It is fascinating how much the lymphatics are impacted by respiration. So we're doing a lot of deep breathing exercises. There's a lot of skin care involved for both lymphedema and lipedema, because especially when you start getting those folds of fat tissue, and you have a propensity for getting fungal infections and skin maceration, stuff like that. So there's a lot we do with skin care to keep the skin healthy and hygienic and infection free. So that's the basic of what we do. And then as far as if there's any medication, so interestingly, this review article came out about the medications that we can use for people with lymphatic disorders to help improve their disorder. And they have medications that encourage lymphangiogenesis or proliferation of lymphatic vessels, and medications that can reduce the fluid load and stuff like this. And so they name all these medications, and nowhere is it mentioned about diet, because ketogenic diet will cause the proliferation of lymphatic vessels, and it will decrease the fluid load. So I thought it's so interesting that, that's what doctors want to go to typically, is you want to go to, some kind of medication. Now, definitely, you might be using an anti-inflammatory. You might have to use some kind of pain medication, because there might be an orthopedic pain or other kind of pain, that arthritis pain, that is not being helped by diet. And so definitely there would be some medication. There might also be a need for surgery in some cases. If you might need to do like a massive debulking of fatty tissue, rather than like a liposuction type of thing. There's some microsurgeries for lymphedema to divert the fluid around the area of obstruction. So lymphovenous anastomoses and lymph node transfer and stuff like that. So there are definitely surgical and medication applications, but I always want them to do lifestyle and diet first to see how much we can progress there.
Yeah, I mean, Catherine pointed out, and the pictures, the stages 1 through 4, I believe, and I would assume how long does it take the typical person to progress through those stages? I mean, you don't pop up at stage 4 in 2 weeks. I mean, that's probably years and years, I would imagine. And so, how much outreach is there for early treatment with this stuff? And I would imagine, like anything, the earlier you get to it, the better the outcome is going to be. Is that fair to say?
Absolutely. And I would say that early treatment is much more accessible to someone with lymphedema, because it's not seen as like, oh, that's just a poor willpower lifestyle issue. So that is happening for early treatment there. But for lipedema, because it's seen as this is just, your poor willpower, you're not controlling your weight, it can get to outrageous proportions before anybody says, well, I think you might have lipedema, and let's start doing some of these conservative measures. So as the awareness of lipedema is improving, I think that there is definitely a shift towards, let's get everybody over to liposuction. Because, the outcomes of liposuction has been that I think, because we're removing a lot of the inflammatory tissue, that the pain reduces very, very quickly after the surgery. There's been, some unfortunate adverse events, like, in the onset of lymphedema and other things like that, or the deposition of fat elsewhere after you've done the liposuction. But that is definitely, people have gone to doing a lot of liposuction treatments. And even one surgeon is actually recommending that as soon as you're identified at puberty of having a lipedema, we ought to do liposuction right away to prevent that valgus deformity that you spoken of. So because as soon as they put on that huge deposition of fat in the lower body, then you tend to get that knee deformity. And so he was saying that we should, that is his mode of early intervention, which I think is quite extreme. I would rather get a hold of them at puberty and have them change their diet.
Yeah, I mean, certainly that's a better way to go. And I think, now that in retrospect, I probably saw a lot of lipedema over the years as an orthopedic surgeon. We didn't know what it was. look at this woman's got huge legs or something like that. But I can remember one male patient in particular that it was just, I'd never seen a male like that. And he had a very similar pattern. So he might be one of these few males that actually has that. I'm, thinking about that and, um, what could have been done or could have been recommended earlier. But of course, I had no clue about how to treat disease with diet until many years later in my career.
Mm.
But what is the, as far as the status of lipedema? You said it's getting more recognition. Is there more and more research funding looking at this stuff now? I know we've got just a few minutes left before I have to go, but let me know the state of lipedema, and then also if you wouldn't mind sharing where people can learn more about what you're doing and
Mhm.
where they can go if they're concerned about this or they know somebody that's dealing with this.
Well, and there's been a lot of interest in doing research on lipedema just in the last 10 years. And so there's been a lot coming out, but it's funded by the people who have money. And so you're going to be looking at surgical options. You're going to look at medication options and stuff like that. Because that's who's funding the studies. And so it requires, there has been a few studies with using diet and lifestyle. And so this kind of work is being done with, just a physician who's doing it in his or her practice and writing up a case report paper. So there's not a lot coming out, not big randomized control studies that are coming out about lifestyle and nutrition and stuff, because that's, just poorly funded. But we're working on it, and we would like to do more. You can find out more at our website, lipedemaproject.org, or lipedema-simplified.org are two websites. Lipedema Simplified is the organization, whereas Lipedema Project is nonprofit, but Lipedema Simplified does other programming and is for-profit group. And we do have our symposium coming up in April 29 and 30 and May 1st. So it's a ketogenic revolution for lipedema and lymphedema virtual symposium. And you can go to those websites to find out more about it. May 1st we're specifically talking about carnivore. And I think it's going to be a fabulous symposium. So I hope that people can attend. There's going to be a lot of great information, and it kind of lets you know that you're not alone in the world, especially if you have one of these conditions, lymphedema or lipedema. Then you see that there are people that are looking at the impact that nutrition can have on your condition.
Okay, well, awesome. Well, Leslyn, thank you so much for number one, for being here. Number two, for doing what you do. I know there's a lot of folks, particularly women, that are benefiting from your efforts. So thank you, and hopefully, maybe we can get you back in to talk again down the road if you're willing. So that would be wonderful.
Thank you very much. I enjoyed being here.
Okay, thanks everybody. I got to go, guys. We'll see you all tomorrow. Bye, everybody. Take care.